The human orofacial complex is a highly calibrated biomechanical system. Normal physiological functions, like chewing, swallowing, and speaking, exert a light, regulated pressure of roughly 20 to 50 grams against the teeth and skeletal structures. This split-screen diagram compares that baseline function with the extreme mechanical stress of persistent thumb sucking. The digit applies a massive, escalating force vector, peaking at 1,000 grams of direct pressure against the anterior palate. To understand the sheer scale of that overload, deliberate orthodontic treatment, like braces, requires only 20 to 50 grams of continuous force. The thumb applies up to 40 times that amount. Because of this extreme physical load, the World Health Organization officially classifies persistent thumb sucking as a habit disorder under ICD-11 code 6C90.2. In clinical nomenclature, it is tracked as a non-nutritive digital sucking habit, or NNTS. A kilogram of force applied to the hard palate for hours functions as a sustained mechanical load that overrides natural craniofacial development. Early in life, this behavior is ubiquitous, with up to 80% of infants thumb-sucking to self-soothe, but prevalence drops steeply, falling to 15% by age 4 and less than 5% by age 6. Clinicians draw a strict line between a transient habit and a persistent one. Transient sucking resolves within 36 to 48 months without permanent structural trace. Persistence past 48 months crosses directly into pathology. Once a habit becomes persistent, the exact nature of the resulting damage is determined by the geometric position of the thumb, the total daily intensity of force, and the specific developmental timing. The specific facial deformity a child develops is a predictable mathematical product of these precise clinical variables. The exact topography of dental deformation begins with how the thumb physically sits inside the oral cavity. The geometric angle of the digit dictates the exact direction of the force vectors. Looking at this sagittal cross-section, we can see the mechanics of the palatal position, the most common variation, accounting for 70% of cases. Here, the thumb rests against the hard palate. Force pushes upward and forward against the maxillary incisors, while the lower lip and thumb combine to push backward against the mandibular incisors. Over time, the teeth migrate along these exact vector paths. The upper front teeth procline outward, the lower teeth retrocline inward, and the vertical space between them separates, creating an anterior open bite and a horizontal gap known as an increased overjet. The interincisal position yields a completely different result. Here, the thumb sits directly between the upper and lower teeth. Acting as a static wedge, it physically blocks the teeth from erupting vertically, creating a pure open bite without angling the incisors forward or backward. In the rarest variation, the lingual mandibular position, the thumb rests entirely behind the lower teeth. This reverses the primary force vector, pushing the lower incisors outward and altering the lower arch. In every position, the digit operates as a targeted orthodontic wedge, co-opting the child's natural self-soothing behavior to generate a specific destructive force. This risk matrix maps how total daily duration scales the severity of clinical outcomes. The horizontal axis categorizes timing, awake versus asleep, while the vertical axis tracks total daily intensity, from under 4 hours to over 8. A diurnal daytime habit in the lower left quadrant is usually brief, a conscious response to boredom or stress that rarely causes structural shifts. The danger lies in the upper right quadrant, the unregulated mechanics of nocturnal habits. Nocturnal sucking takes place during deep sleep, removing all conscious control. The jaw muscles lock the thumb in place, resulting in a steady, unrelenting application of maximum force for 8 continuous hours. The duration of the sleep cycle ensures this force remains active for hours without the interruption of speech or mastication, accelerating anatomical deformation. The severity of the damage is ultimately determined by age. Clinicians closely monitor the developmental window between ages 6 and 7, the critical threshold dividing temporary dental shifts from permanent skeletal fixation. If the habit is successfully eliminated before age 6, prior to the complete eruption of permanent incisors. 70 to 80% of mild to moderate dental changes will self-correct. The alveolar bone simply remodels naturally as the teeth erupt. If the habit persists past the peak of palatal growth around age 7, the skeletal loss becomes irreversible. This coronal cross-section demonstrates maxillary transverse deficiency. Under continuous palatal pressure, the maxilla permanently narrows horizontally and pushes upward vertically. This creates a high, narrow shape called an ogival palate. The altered bone structure directly reduces oral cavity volume and compresses the nasal airway passages directly above it, establishing a physical restriction that often forces the child into chronic mouth breathing. The skeletal deformation extends to the lower face as well, locking the patient into a hyperdivergent growth pattern. The mandible rotates downward and backward, permanently elongating the lower anterior face and leaving the chin retruded. Soft tissue adapts to these new bony parameters. As the anterior bite opens, the tongue thrusts forward during swallowing to seal the gap. This atypical swallow creates a pseudo-open bite, applying outward pressure on the teeth that sustains the malocclusion long after the thumb habit stops. Missing the intervention window by age 7 graduates the patient from temporary reversible orthodontic problems to permanent craniofacial and respiratory deficits. To prevent this structural loss, the American Academy of Pediatric Dentistry relies on strict diagnostic thresholds. Clinical intervention is indicated the moment the habit persists beyond 48 months of age. Diagnosis is confirmed through precise physical markers. Clinicians measure for an anterior open bite greater than 2 millimeters, a reduction in maxillary arch width exceeding 2 millimeters, or incisor proclination deviating more than 2 millimeters from age-matched norms. Clinical diagnosis relies entirely on these objective biomechanical measurements, stripping away the subjective behavioral assumptions that often surround childhood habits. Once diagnosed, practitioners follow an escalating 3-tier management protocol designed to match the specific developmental stage and severity of the patient's structural loss. Tier 1, targeted at ages 3 to 6, centers entirely on behavioral counseling. Clinicians work with parents to implement positive reinforcement and address underlying stressors, strictly avoiding shaming or punishment, which reliably amplifies the anxiety driving the habit. For habits that persist past age 4 or occur largely during sleep, treatment escalates to Tier 2. This 3D rendering displays a palatal crib, one of several fixed habit appliances bonded directly into the patient's mouth. These appliances are not designed to cause pain. Instead, they act as a physical barrier that prevents the thumb from making a suction seal against the palate, instantly eliminating the behavioral reward of the habit. If the habit persists past age 7 and malocclusion is established, Tier 3 intervention is required. Orthodontists must use rapid palatal expansion devices to mechanically force the narrowed maxilla back to its proper transverse width, followed by braces to close the open bite. By identifying the force vectors and timing of NNTS early, practitioners can mechanically intercept the habit. Doing so rescues the patient's craniofacial trajectory before major surgical intervention becomes inevitable.